I wanted to talk very briefly about maybe some future directions that we and others have been involved with the screening for early pancreatic cancer, and then a few words about this evolving world of personalized medicine. There are new medications coming down the pipeline, and the dream is that one day we will have more than one or two medications to choose from, and we'll be able to self-select patients out to give them the best treatment possible. So first, issues of screening. Why screen? That's fairly straightforward. What do we screen for? Who do we screen? When do we start screening? How often do we screen? How do we screen? And if we find an abnormal result, what do we tell the patient? So who do we screen? So we know for a fact that there are groups of people, and this has really been the benefit of the last 10 or 15 years, this kind of focusing down on the issue of trying to find the high-risk groups of patients within pancreatic cancer. They probably make up 10 or 15% of the entire group of patients with pancreatic cancer, but it's somewhere to start. They include people with pancreatic cystic neoplasms, a variety of hereditary or genetic disorders, and then this large group of patients that really was ignored for a long period of time, and that's patients in whom there clearly is a family history of pancreatic cancer. And often the penny hasn't dropped with the patients themselves that this is running, that this could be a reality. Everybody knows about the family history in breast cancer and colon cancer, but it really takes a lot of pushing to get people to understand that there is a family history issue in pancreatic cancer. The more family members that you have affected, be it 1, 2, or 3, the increasing risk that you will develop or somebody in your family will develop pancreatic cancer. But again, the rate of BRCA2 mutations, even in families that have 3 first-degree relatives that are affected by pancreatic cancer, is still only 17%. So people are still on the hunt for this kind of elusive gene or genes or collection of genes that define why does pancreatic cancer run in certain families. So this is an ongoing area of work. Obviously, if it was a simple blood test to define risk within a family, we'd all be rushing out to recommend it for our patients, but it's still a work in progress. To jump down to the next question of how exactly do we screen? And ideally, we would like a very simple, non-invasive test. So ideally, if we could do a nice blood test or look at pancreatic juice or stool, we've been looking at saliva, and very much like other groups have come up with a panel of markers that is suggestive that we can diagnose or at least pick up pancreatic cancer in patients that have it. But the question is, are we picking it up early enough, or will we be able to pick it up in high-risk groups? So again, it's still very much a work in progress, and only time will tell whether any of these, including blood, pancreatic juice, stool, or even saliva, will be the first port of call for people who are being screened for pancreatic cancer, be it the high-risk groups with a family history, or even the general population that are out there. I'll thank you for your attention.